Good morning, everyone, and welcome. Welcome to our annual continuing education event. And I'd like to offer a special welcome to all of our alumni who are returning for alumni reunion activities. Those of you who are alumni and in the audience, would you just either stand or give us a big wave? Yay, well, welcome home. We're so glad to have you. Look forward to interacting with you more during the weekend and hope you'll take full advantage of all the activities that are planned for you. And one of those is to meet some wonderful students. We happen to have some seniors and some graduate students in our audience today. So current Creighton School of Nursing students, would you give a big wave so they can kind of see where you're clustered? You're going to be so impressed by these young men and women. They are phenomenal, and we're so proud that they will continue the outstanding traditions that you, our alumni, have put in place. So you've got some wonderful people following in your footsteps there. We also are so excited today to be able to welcome our Allegiant Creighton Health colleagues. If the staff from Allegiant Creighton Healthcare are here, could you give us a wave as well? Yay. We're not even into our first full month of the merger, but we're thrilled. We're thrilled by the possibilities. We hope to highlight some of the interactions and opportunities that we have before. We've long had direct clinical consistently through Allegiant Health, but we know that even more activities are now afforded to our students with this relationship, as well as our work with Catholic Health Initiative. So very excited about that. We have some members of our Alumni Advisory Board here today. I'd like to ask them to actually stand and please join me in giving them a thank you for all the work that they do on behalf of the School of Nursing and our Alumni Association. Would the board members please stand? You up there and there. Thank you. We'll be meeting later. And we also, I'm not sure if she's registered yet, but she was outside. Kathy Soto is with us. Kathy, have you gotten in here yet? Okay. Kathy serves on the National Alumni Board for the entire university, so we're glad to have nursing representation there. With that, I'd like to start off with just sharing a little prayer with you from the book, Hearts on Fire. It's Praying with the Jesuits. So in recognition of your time here and hopefully an opportunity to interact with the Jesuits this weekend, want to start off with one of the prayers from the spiritual exercises. It's called What I Want and Desire. It's a very short prayer. So it's, I ask the Father to give me an intimate knowledge of the many gifts I have received, that filled with gratitude for all these gifts, I may in all things love and serve the divine majesty. And that's what we're about today. We hope that you will be blessed by the gifts and talents of our wonderful presenters and the work that they've put into this, as well as the many activities over this alumni reunion weekend. With that, I'd like to start our continuing education session for today. We're focusing on the topic of caring in a complex world. We're going to use that overall theme for these annual programs for a couple of years, but changing the focus of what is the complexity that we're dealing with. The exciting thing about healthcare is there's always something new, something that we're trying to respond to and develop. For those of us who've been in healthcare for a while, we have seen so many changes. Some of us lived through DRGs and prospective payment system transition and wondered, how on earth are we ever going to do this? But we responded with creativity and with, in many cases, grace and wonderful ideas, and enhanced our healthcare systems. And we're continuing to see more and more complexity, more and more challenges. But I am confident that we'll continue to respond to those challenges with ideas and incentives for our patients, as well as ways to improve the health care of all. This time we're looking at reducing readmissions. So what's the emphasis? Why readmissions right now? As many of you are aware of, with the Affordability Act, or the sometimes referred to as Obamacare, but with the legislation, we know that as of this October, that hospitals will be held accountable for readmission rate, and we'll talk about that more. But how is that impacting all of us? How are we changing educational systems? How are we changing our healthcare systems to respond to these? So our wonderful presenters will be able to share different aspects of how we can respond, where the challenges lie, and what needs to be done as we move forward. So we're going to talk about what is the nature of the readmissions right now, what's preventable, what do we know, what are some of the cost and quality forces that are driving redesign and integration of healthcare delivery services, what approaches are we using to address avoidable hospitalization, to more effectively and efficiently use our healthcare resources and enhance patient and provider relationships, and what's academia's response, not only in nursing, but throughout the health professions. So I'm excited that we'll have our colleague from medicine to talk about interprofessional care and how we're all responding. And we're going to just talk about how healthcare professionals can be prepared for future needs of our workforce and our healthcare delivery system. Each of the presenters have listed that they have no financial interest or arrangement that would be considered a conflict of interest for this presentation. And I'd like to add that they're all donating their time and talents to this session. So we're going to start off with avoidable hospital admissions. Just kind of an overview. What do we know from some of the demonstration projects, and how are provider performance expectations and roles shifting in response to some of the changes in the incentives for hospitals and other providers. So hospital readmission, what we know about this right now. Currently, about 20% of the Medicare fee-for-service patients are rehospitalized within 30 days. Now, this is based on 18 months of claims data that was analyzed 2003 to 2004, but this will be the consistently quoted statistics. So that's where that data come from. So basically 1 in 5. And it's Medicare fee-for-service patients that were analyzed. So that excluded any Medicare patients who were part of a managed care program already. And so keep that in mind, that that's these statistics. And one of the things that they also found of these patients once discharged, less than about 50% had no bill, there were no claims for any office visit between discharge and returning to the hospital in 30 days. Furthermore, analyzing that same claims database, 31% were rehospitalized within 60 days, and 34% were rehospitalized within 90 days. Breaking that same group down a little bit more, 67% were discharged with medical conditions, were rehospitalized or died within the first year post-discharge. It's a very large number. 51% of the patients discharged after surgical procedures were rehospitalized or died within the first year post-discharge. You can see from this map, too, there's a same data set, a tremendous amount of variability in hospital rehospitalization rates post-discharge. The white states, which includes Nebraska there, have some of the lowest rehospitalization rates. The very darkest states are those that have the highest. And in those states, the findings were 20% to 23% were rehospitalized within 30 days. So a large amount of variation. Now, cost of readmission. Some have placed that, at this particular study that I just referred to, placed it at anywhere from $12 to $17 billion per year in Medicare hospital payments based on this readmission. Now, some of the statistics have shown that probably $12 billion is preventable, but that varies depending on who you look at. But important for us is the perception that readmission is an indicator or marker of poor quality in our healthcare system. But even that, there's a great deal of controversy and variation in opinions of, is readmission truly an indicator of poor quality? In some cases, it seems to be an indicator of being more efficient or more effective. For example, the incentives to us as we put the prospective payment system into place was early discharge. We've seen amazing changes in the length of stay and the ability to transition patients out of the inpatient acute care environment and back into home or a lesser level of care very quickly. So in some cases, that's very effective. We also know that there are a lot of risks from staying in a hospital for a long time. You're exposed to more possibilities of complications, hospital-acquired infections. So early discharge, moving patients through the system very quickly, is a very positive thing in some ways. So it might be better to incur some readmissions by being able to get more people discharged earlier. So we don't know that that is necessarily a bad thing, to transition people out very quickly. The mortality rate's another factor. As hospitals that are able to really lower their mortality rate, some have seen a higher readmission rate. Again, is that a bad thing? Are we able to save more people, able to transition them out of the hospital and back into the home, and willing to accept a little higher readmission rate because you were able to get them better, people that might have died? Because, quite frankly, if a person dies in that 30 days, or even in the hospital, you don't incur a readmission. So are you trading off mortality if you're trying to avoid readmission? So there's a lot of controversy. There's a lot of more we need to really understand about readmissions and what are the costs. But by far, the prevailing thought is that a readmission is not a good thing, an unplanned readmission. Some of the causes of avoidable readmissions I've listed here. And there are certainly many more, but these are kind of the top list. That is that we prematurely discharged people, or that they incurred a complication, such as a hospital-acquired infection that wasn't seen until after they were discharged and the error was found and they have to come back. One that we will talk more about today is the failure to coordinate care. We know, just like I mentioned, the fact that less than 50% of those discharged in the claims data set that looked at the 20% readmission rate, less than 50% of those had an office visit during that 30-day period post-discharge. So are we coordinating care with the primary care providers in the communities and those who are responsible for the patients after they've been discharged? And you have to put this in the context as well as how we've been changing healthcare systems and hospitals in particular. By hiring hospitalists and intensivists, we're actually now separating, if a person has a regular source of care, that person is no longer following them into an inpatient setting. So how are we communicating with the patient's regular provider either that they've been admitted or that they've been admitted and discharged. So we haven't quite worked that out. And while we know hospitalists and intensivists are improving quality of care while the patient is in the hospital, we haven't necessarily had the incentives or the information systems, the electronic data exchange, or the communication process in place to communicate with those in the community-based care settings to talk about what we've done. In many cases, when a patient who's been recently hospitalized goes to their primary care provider post-discharge, the providers have no records. What happened, they don't have the lab work, they don't have the results. We could carry that as well into long-term care settings and others, the lack of interchange of information. And it's definitely compounded by the fact that we have so many different electronic data management systems, and our systems are not linked. The failure to reconcile medications is a huge one, making sure that we know all the medications patients are on, coordinating that, making sure that patients understand that, the medications. Working with pharmacies, very rarely are there shared databases even between the patient's regular pharmacy in their home town or their setting and the discharge plan. So a lot of different areas we need to work on through that. The inadequate communication among hospital personnel, the patients, the caregivers, community-based clinicians. As I've talked about, we don't necessarily have those processes in place in all settings. The poor planning for care transitions as we move from one level to the next. We know in nursing we've been working very hard on handoffs and trying to improve communication, but even among specialists and primary care providers, how we're dealing and planning for the care transitions for our patients. There's also research that shows the supply of beds and even the supply of physicians in the local market will determine whether you're readmitted or not, as well as variations in practice. Because of the differences in geographic admission patterns and regional variation, we know that not all of the readmission is related to the condition of the patient. So we know that there are some factors. But in every case, we don't have clear consensus. There is not clear evidence across all these of what are the truly most important causes to work on. So we're seeing tremendous number of interventions and different kinds of demonstration projects to try to understand this better. So the percentage of preventable readmissions, if you take the claims data set that I mentioned off in the beginning of this presentation, the work by Jinx and others, they basically found a range from anywhere from 2% to 78%. Tremendous amount of difference. They placed it at around 27% of readmissions were preventable. Another study, 12%, if you just use clinical data. If you only use administrative data, the kind of claims data, 59%. But a very important factor is Congress heard from the Medicare Payment Advisory Commission, which is one of the most important policymaking group in payment for health care, said that 76% of our readmissions could be prevented. So, frankly, that's where a lot of this is being driven from, looking at that huge number. So as the healthcare policy was being developed in 2008 and leading up to the 2010 Affordable Care Act, these figures were seen as a way to pay for all of the new changes that were going to come into play with the Affordability Act. So if we can save 76% of the cost of readmission, that would be phenomenal. So a number of incentives were put into place in all the demonstration projects as well as in the subsequent legislation. These incentives were put in place to enhance care coordination, to enhance care management, and enhance care transitions, as well as probably less emphasis, but the need to improve communication. Most of the needs for communication have been focused on provider to provider and building in the electronic health records. But also we had, as we'll hear more about from Dr. Amy Abbott, looking at patients and providers and how patients can take a bigger role in managing their health information. The readmission reduction program was one of the types of programs that was put into place as part of the Patient Protection and Affordability Care Act in 2010. Basically, I've got the provision of how it's being defined, and that is any short-term acute care hospital that originally discharged a Medicare patient to a home or to another short-term acute care hospital is at risk for a reduction in Medicare payment if the patient has a diagnosis of acute myocardial infarction, heart failure, or pneumonia. So we're looking at 3 conditions. They have any of these 3 conditions upon discharge. And if they're admitted to the same or a different short-term acute care hospital in 30 days or less from discharge, but with any acute condition. So it's not that they're readmitted with that diagnosis or a complication of that diagnosis. If they're readmitted for any acute care problem within that 30 days, then the hospital is at risk for reduction in payment. That reduction in payment is starting this October. It's capped right now at 1% for this coming fiscal year. After that, it will be 2%, and after that, 3%. Each year, the Secretary of HHS will have the opportunity to add more conditions as part of the analysis of that. So they'll be expanding the number or the types of conditions. So the data set will be based on those 3 areas, but it will impact every Medicare patient. So for example, the figures that are going into play this October are based on an analysis of the hospital's readmission rates for those conditions for the period 2008 through 2011. So the hospital now knows, and we know that over 2,000 of our acute care hospitals are receiving what's called these penalties right now. Most are very low, but again, about 2,200 of the hospitals are incurring penalties. So if they charged $20,000 for a surgical procedure or some kind of procedure charged to Medicare, and they're one of the hospitals that have a 1%, then they will see that 20%, $20,000 reduced immediately by 1%. So that's how this works. So every year that will be analyzed, and payments, reductions in payments will be introduced. The risk standardized readmission measures for those 3 conditions have been developed and endorsed by the National Quality Forum, and those will continue to be the measures that are used in the quality determinations. So some of the interventions that we're all trying, whether part of demonstration projects or just because it's the right thing to do. And I have to applaud most hospitals. They were putting these things into place well before there were the carrots and sticks to make these changes. But I've used Hansen and others' kind of taxonomy to characterize these into pre-discharge interventions, post-discharge interventions, and bridging interventions. So in pre-discharge interventions, some that you'll see are patient education, medication reconciliation, discharge planning, and scheduling a follow-up appointment prior to discharge. So putting that into place, all of those things before someone's discharged. The post-discharge interventions that are receiving a lot of attention and research are follow-up telephone calls, patient-activated hotlines for changes in symptoms, timely communications with ambulatory care providers, timely ambulatory care provider follow-up, and post-discharge home visits. And the bridging interventions are things like transition coaches, physician continuity across the inpatient and outpatient setting, and patient-centered discharge instruction. So there are demonstration projects that have looked at this, and Hansen and colleagues did a retrospective analysis of all these interventions and found that no one single intervention alone was able to impact readmission rates. Medicare put into place a number of demonstration projects, but I want to focus on one right now, the Medicare Coordinated Care Demonstration Program. There were 15 demonstration programs that started in 2002, and 4 of the 11 demonstration projects that reported in this study reduced hospitalizations for Medicare beneficiaries who had chronic conditions, and they reduced these anywhere from 8 to 33%. Some of the interventions from that list that I mentioned before that they used and found effective were supplementing telephone calls to patients with frequent in-person meetings, occasionally meeting in person with the providers, and that was the care managers doing that, acting as a communication hub for the providers, delivering evidence-based education to patients, providing strong medication management, and providing timely and comprehensive transitional care after hospitalization. Now, the providers of most of these services were what they called care managers, and these were, for the most part, nurses, occasionally some social work. So nurses played a vital role in the effectiveness of working in this demonstration project. And one in particular I wanted to talk about is not too far away, just down in St. Louis. It was affiliated with Washington University School of Medicine as well as Barnes-Jewish Healthcare System, where they found that the nurses took on the 20% of the most high-risk, chronically ill patients who were discharged from the system and truly coordinated the care and worked exquisitely with their clients and have had some phenomenal results from their work. So nurses have a very strong part to play, but nurses also communicated very well with the nurse case managers, with the physicians in primary care and the other primary care providers, and spent time visiting with them, making sure records were provided to both the patient and the providers so that they all understood how care was transitioning. So there are many, many other interventions and more detailed projects that we'll hear about, as well as some of the quality indicators.